Sorry for the delay. And on behalf of Seashore Memorial Hospital and the ASAM, I will welcome you and give some kind of an introduction before we begin the whole body approach today. And also, this course is organized by the WeFocus, ASAM Board, and Taiwan Society of Emergency Medicine, and Taiwan Society of Ultrasound in Medicine, and also our hospital. And welcome you. This time we have two kind of courses, WBE and life support courses in Seashore Memorial Hospital at the same time. Now we are running the life support course, and welcome you. We have 7 countries participants to be with us, and also 7 countries, faculties from 18 faculties to support us. And this is my hospital. And you have seen Luca, right? And the faculty supporters also got Gabriele Villa, now is running the WBE course at the Clinical Training Center right now. We have faculties from South Korea, and we have also faculties from Singapore, Francis here, and On, and Tao. Also got faculties from Japan. And Adi Osman, the president of Success Sonography Society in Malaysia. And Jan, also faculties from WeFocus Hong Kong. Herman from Hong Kong, and Professor Chu. And last year we have a great conference at the Wapa. And also got Dr. Chen from Taiwan, and Son, and Tsai, and Dr. Wu, Ling, also Taiwan faculties, and Tsai, Rocky guitar. Okay. Also, I am Dr. Kuo Chih. So we start these topics. I will start from the airway, because lost airway, we lost everything. So how to control the airway? Great pictures, right? Handmade ultrasound sketch from one of our excellent friends. And we talk about the ultrasound enhanced protocol. We start from ABCD way. I start from the first beginning, because we apply focus ultrasound, or we call it POCUS. POCUS means that point of care ultrasound, to answer the target questions at the critical moments. It may be lung, it may be IVC, gallbladder, different kind of focus. One is airway, and the focus means that goal-directed, problem-oriented, limited, but at that critical moment, for the clinician to provide high quality in timely care. So it could be systemic, and it could be point of care with ultrasound to enhance the critical management, not only for assessment, but sometimes can provide the guide for the treatment. Like this case, we have 9-year-old girl got a lump over her neck. We can see this neck lump here. I'm worried about is this kind of deep neck infection got airway crush in the coming hours. So we have to manage that kind of problem, to assess and even provide the management for that. Because if we lose the airway, we've got a blood and a deadly patient. So this topic I will focus, because airway we have too many topics to share. I will talk about the trachea, especially the intubation. These protocols is provided by the Luca and the WeFocus about nearly 10 years ago. It talks about the whole body approach, ultrasound enhanced critical management cycle. Start from the age, and you can see it depends on the patient's problems. You may encounter airway problem, B problem, C problem, and etc. After the assessment, you may provide the intervention. The intervention may guide your airway management, even traditional way to confirm or provide a good entrance route to manage the airway. The other fluid management and intervention assessment will be discussed later. So how to choose a best probe to assess the airway? I would suggest a linear probe will provide a better resolution. But if we use a whole body weight, maybe it will not a best one. If you've got a portable one, like this portable one I have, I can assess the shallow part and even the deeper part. I will also share with you experience use this pocket-sized ultrasound to assess that girl with a lump there. So we have patients got air problem, may even have a breathing problem. So how do we apply the ultrasound to assess the airway? There are some locations you can put your probe on for airway assessment here. And for the lung and for the circulation, we have different kind of location. Access airway, we put this location. After put the tube in, if we want to check for the bilateral ventilation, I would suggest the bilateral lower part of the lung to access the best sliding phenomenon. And if you are encountering problems suspect to having pneumothorax, you may put the probe on the anterior and the uppermost part to assess for the pneumothorax. Just like this way, we have this probe position. This is curvilinear probe, and we can see that the airway, air track. And here is a video we how to apply that, maybe during the resuscitation. Okay. Then we can see that under curvilinear probe, we can access that. Put the probe transversely on the suprasternal notch, you will see the airway, like this air track phenomenon, just like Professor Chu has already told us that this looks like air, the physiology. And here we can see the trachea. If you got time, but sometimes it is time limited. So if you see only one track, that means you mostly is safe. And then here we can see a better evaluation using linear probe. You can even see measure the length, the diameter of the trachea, and if the trachea got some kind of problem, you can also evaluate the trachea. Here is the esophagus. So after we know that, we can also evaluate the vocal cord. So, using ultrasound, I think deep neck infection is no more difficult situation to access. You can use ultrasound to access a different aspect of the airway. You can see this. We can also see the vocal cord to move. And a great study published by Dr. Cho, also faculty from Taiwan, now is in States to got his emergency medicine residency there. Their groups published a great public called TRUE, Tracheal Rapid Ultrasound Examination. See, normal trachea. After intubation, you can also see only one track. If you see this double track side at the same time, that means your tube may put into the esophagus to expand that to produce the other air track. This study means that it is feasible and rapid. The accuracy is about 98%. I think that is a good complementary tool. The time is also save a lot of time. See, about 6 seconds you can confirm the airway. After that, they also got follow-up study to see that it's ultrasound able to access the ventilation compared to the X-ray. The time is also saving. The positive predictive value is also high to assess the bilateral ventilation. The editorial of the resuscitation also compared that. Using a traditional way to confirm the endotracheal tubing, you may use the capnography. May take about 6 ventilations. It takes time, but use ultrasound. may take 6 seconds to confirm that, and extra 6 seconds to confirm the bilateral ventilations. So it's quite promising tool to provide good complementary information about the endotracheal tube. See this one, a real-time video recording during the intubation. See again? Here we can see only one track. After the tube in, we only see one air track. That means the airway is in the correct position. Also confirmed by the auscultation and capnography. We all know that different kind of guidelines suggest you use primary and secondary way to confirm the endotracheal tube. And this one is an incorrect one. As you can see, we got another tube. See here, double track sign. So if we see that, we should not proceed to the other baking, and we should remove the tube. And sorry, the other video also got an incorrect one. So, based on ethical consideration, we should not continue and to see that, okay, it's not in the good position, right? So we got a direct visualization scope and different kind of technology. And this is the newest guideline, 2015 HA guidelines also cite this excellent paper to say that ultrasound transducer transversely suprasternal notch to check for endotracheal tube or esophageal intubation. Also, it can use to assess the pleural movement to evaluate bilateral ventilation. Excellent result from the newest guideline. So we have to follow the evidence, right? Not only expert. After put the tube in, assess the ventilation. If we assess ventilations like this, we can see lung slide, because air in puts the lung to move. We call it base sign. We'll talk about that more in the following section. And here we can see ventilation. It would be obvious on the lower part because the diaphragm will move the sliding more obviously to let us to get the correct information. Like this one. Has anyone seen the lung slide? No. Yes. So if you are trying to figure out, and if they some suspicious about the pneumothorax, you will put the probe in correct position. This patient lying supine, so put the probe on the uppermost position to check that. Let's see correct and normal lung. You can see the comparison between these two, right? So if this is a critical moment, you got these two kinds of information. It will enhance your management. So let's see a consecutive movement of the how to assess. After the tube in, put the probe on the basal part of the lung, right part and left part to assess for the ventilation. If you've got time, you can also put the probe on the anterior surface to see the lung slide or even other artifacts produced by the consolidated pneumonia or interstitial syndrome. Just like this one, if you're familiar with the neurology, you use the motion mode, and you can see that artifact here to just push like a C wave and send seizure sign. See this rural pneumothorax. See this kind of barcode stratosphere. You have to suspect this patient may have pneumothorax, but you have to consider at that moment the patient's conditions, because the specificity is not 100%. You have to make sure that. But if you see this kind of artifacts, B-lines, vertical artifacts, we can also rule out. Sometimes rule out is also a good and important information for us, emergency physicians, or for some of you work in the ICU. Because for ICU patients, we all know that X-ray is not a good tool to assess for the lung condition. And then the pulse status, we can also exclude the pneumothorax. Here, we got a 100% specificity can use to confirm the pneumothorax. And the true, the follow-up study is the same. So I will go to how to apply the true to evaluate the intubation. Okay, we see only one track. And then you can see, you got to familiar with the, your function of your machine. Because you assess the airway in a shallow view. And to assess the sliding, you need to adjust into a deeper evaluation, right? Then we can see better ventilation at the bilateral lower part of the lung. That's conventional way, traditional way to confirm airway. But if we got difficult airway, if we got problem to put the tube in, we may to identify where is the adequate position to put maybe jet ventilation, maybe cricothyroidotomy, and even surgical airway. You have to find some safe zone and safe entrance site. Sometimes it's difficult, but it is accessible. This, we use a linear probe in a longitudinal way. We can see cricoid cartilage, thyroid cartilage, the air on the tracheal surface. Here, we see the cricothyroid membrane. You can see the target. If you got the access and the situation is needed, you find a good position to put the tube in. You can also assess the surrounding structure to avoid possible complications. Here we come back to the girl. Here we can use the linear, use the pocket size one. Not an excellent resolution, but it is okay to assess the point of care problem. Squish sign means that here we got some dirty fluid inside. Got red means got leukocytes, got fever, we know that. He has a deep neck infection and abscess collections at his left side. What is the mark of this purple mark? Is her cricothyroid membrane. So in a midline, you can see that this abscess pushed the airway into very extremely right side of the neck. We can see here, from this way, I put the probe transversely and move rightward, airway, and see this abscess. Right now, this girl has no difficulty breathing, so I will just mark it and to prepare for possible surgical airway for her. Luckily, we can safely transfer this girl to the operating room to do the following procedures and definitely airway management. Here, I put the probe longitudinally, cricothyroid cartilage and the thyroid cartilage, and see the cricothyroid membrane. Previously, we can only image, maybe here, maybe there, but you have no exactly location, so you will encounter problem. Now we can see directly and even mark there. So it provides a visual enhancement. It's echo sonography enhancement to assess difficult airway, assess the airway, and even prepare for the surgical airway. Now we got the other young adult, also got neck and chest pain. Sometimes you will see some air over the neck. Where is the air? We know that air will produce a bright and dirty shadows. And here it is the airway. What's the differences between this airway and the initial normal airway? The difference is you cannot see clearly the structure beneath. Here, masked by the air, and disappear of the air because of all these are free air. This air is located at the subcutaneous tissues. See, here is a minimal air and block all the airway, and even we cannot see clearly the carotid and the jugular vessels masked by the airway. So we know that this is subcutaneous emphysema. Again, you have to trace back to patient's clinical history and physical examination. If this patient has no fever, no other signs of infection, maybe it's because of the spontaneous pneumomediastinum or some kind of situation. But you know that this patient has no simple musculoskeletal pain. X-ray is, see, for this minimal air, we have difficult to access this, maybe here, and may even to see some air around the mediastinum, the lateral view of the neck. Then, last week, we also encountered a difficult situation. 4-month-old girl brought in by her father because of difficult breathing. Here we encountered this situation, got difficult IV access. So we have difficult to paralyze this girl. We have to intubate immediately because this girl got, this baby got difficult air hunger and difficult to ambulate. Then our attending physician put the tube in. Again, questions for you. Is this position correct? Is this a correct endotracheal tube intubation?
No.
No, right? Why? Double track. Easy to differentiate it even before you ventilate into her stomach. We see double track, real-time pattern. All right, and then we put the we pull it out and to get the ventilation, and then try again. How about this time? Again, real-time intubation. Is this tube in correct position? It's a cyclic view, all right? Is this a good, correct position, trachea or airsaw? Really see double track? This is the airway, because this girl, this baby is not paralyzed. She also got like this way. See, we have difficult to hold her head and put the tube in, and also got limited space to see this. We do not see double track, right? We don't have double track. And we can see, if you, here, we can even see the clear, the tube into the trachea. But we also see some strange structure along her neck. It is correct, so we move on to check the rest. After we put the tube in, we feel confident to give sedation and paralyze this girl to let her count and to provide better oxygenation and ventilation. The tube can be accessed directly, especially for those young adults and young patients. See, longitudinal view, you can see clearly the endotracheal tube in a dynamic way. And here, sometimes you also got difficult problems to encounter. This is the first time I see these structures. I don't know what this is, but at the same time, I asked the pediatrician, what is this cystic, and also these materials I'm familiar with that, blood. And this structure is not blood vessel. It's called hemangiolendangioma. Quite difficult for us, right? If you're not a pediatrician, how can you remember this long-term disease? I think the time is limited, so I will skip the last video. And to save time, I thank all the good friends in Taiwan. We have a good group. We had some discussions before to make our ultrasound development in Taiwan getting a better situation. Here is my contact information. I also got lots of video clips on my YouTube and even my Facebook. If you got interested, you can add this, and you can also add my to search the emergency ultrasound training center. on Facebook, you will see lots of video clips I share on the web. Thank you. Now, it's again Lucas time. Welcome.